Good afternoon, class. I'm Joseph Anderson, and today we'll be reviewing heart failure, compensation mechanisms associated with heart failure, diagnostics, and treatment of heart failure. You can follow along in Chapter 20 of your Essentials to Pathophysiology textbook. By the end of this video, the student will be able to define heart failure, describe how the compensation mechanisms affect the body, explain the effects of prolonged exposure of the hormones released by the compensation mechanisms, and identify 4 drug classes used in the treatment of heart failure. Heart failure can be caused by a functional or structural impairment that reduces the heart's ability to effectively supply the body with blood. The impairment either affects the heart's ability to fill or pump blood throughout the body. Coronary artery disease and hypertension are 2 of the most common causes of heart failure due to the stress that they exert on the heart and vessels. Heart failure is the most prevalent in the elderly population, but African Americans are frequently affected at a much earlier age. While the prognosis for other circulatory diseases has improved over the years, the mortality and morbidity rates of heart failure have continued to grow. The decrease in cardiac output caused by heart failure leads to the activation of compensation mechanisms that seek to preserve blood flow to the nervous and circulatory systems. You can refer to Figure 20-2 on page 489 in your textbook for an illustration of the different compensatory mechanisms that are activated during heart failure. Once there is a decrease in cardiac output, the sympathetic nervous system releases epinephrine and norepinephrine, also known as adrenaline, into circulation. Adrenaline stimulates the heart to increase the heart rate, heart contractility, and the vascular tone to increase cardiac output. The compensatory mechanisms greatly reduce the amount of blood flow to non-essential organ systems. Extended circulation of adrenaline will eventually lead to decreased cardiac efficiency, which can result in shock or death. While the sympathetic nervous system seeks to maintain blood flow to the circulatory and nervous system, decreased blood flow to the kidneys leads to the activation of the renin-angiotensin-aldosterone mechanism. The renin-angiotensin-aldosterone mechanism increases the circulation of renin, aldosterone, and angiotensin II to promote water and sodium retention, as well as increasing vasoconstriction that also leads to increased blood pressure. Prolonged circulation of aldosterone can lead to ventricular stiffness, which will further decrease cardiac performance. Prolonged use of the compensation mechanisms leads to cardiac tissue damage and arrhythmias. Tachycardia, vasoconstriction, and prolonged circulation of angiotensin II and aldosterone can cause cardiac tissue damage by increasing the demand of oxygen by the cardiac muscle, increasing vascular resistance, and stiffening of the ventricles. In addition, exposure to adrenaline can cause arrhythmias, which if not corrected can lead to death. The following slide is an example of supraventricular tachycardia, which can occur in heart failure. Patients will often experience chest palpitations, shortness of breath, lightheadedness, and fatigue, as well as chest pain. Supraventricular tachycardia is characterized by a heart rate greater than 100 beats per minute and is caused by electrical impulses occurring above the two ventricles. There are several methods for diagnosing heart failure. The unique physical characteristics associated with heart failure, such as jugular vein distension, edema, and pulmonary congestion, make physical examination a useful component for diagnosis. To confirm a diagnosis of heart failure, further diagnostic studies will need to be performed. Brain natriuretic peptide, or BNP, is a laboratory test used to test the serum concentration of B-type natriuretic peptides, which are released by the ventricles in response to increased ventricular pressure or fluid overload. BNP levels will always be elevated in patients with heart failure, making it a very effective tool in confirming a diagnosis of heart failure. Echocardiograms are used to determine the ejection fraction, as well as to visualize the ventricles, wall thickness, and any heart defects, making it an essential component to a diagnostic workup for heart failure. When performing a physical assessment on a patient with heart failure, you will notice that their jugular veins are distended or engorged. This is due to the increased fluid volume. Another assessment finding caused by the increased fluid volume will be edema. The edema can either be pitting or non-pitting. The picture on this slide is an example of pedal pitting edema. You'll note that the pitting edema is right next to the ankle here. An important assessment question to ask your patient is whether the edema is new or a chronic problem. This slide shows an example of an echocardiogram with landmarks of the heart next to it. Please review this slide to see how an echocardiogram views the heart. Treatment of heart failure may include several medications as well as non-pharmacological approaches depending on the severity. Exercise training and diet are strongly recommended non-pharmacological approaches to treatment. Dieting should focus on fluid and sodium restrictions. Patients may also require the use of oxygen therapy and a continuous positive pressure device, or CPAP. CPAPs are recommended because they can potentially reduce the preload of the left ventricle, thereby improving the ejection fraction. Pharmacological therapies will be discussed on the following slides. Diuretics are frequently prescribed for the treatment and management of heart failure due to the edema caused by the renin-angiotensin-aldosterone mechanism. Diuretics promote urination to reduce the fluid volume, which in turn improves cardiac output as well as preload. An important clinical consideration when administering diuretics, such as Lasix, in large doses or intravenously, is to determine if the patient requires catheterization, especially if their mobility or cognition is impaired. ACE inhibitors are used to inhibit the conversion of angiotensin I to angiotensin II. If you'll recall from the renin-angiotensin-aldosterone mechanisms, angiotensin II stimulates aldosterone production, which increases sodium reabsorption and water retention. It also increases the body's level of antidiuretic hormone, or ADH, and can lead to ventricular stiffness. If you'll refer to the left side of the graphic in the slide here, you'll see that the ACE inhibitor blocks angiotensin to angiotensin II, which stops the kidneys from absorbing sodium and water, or retaining sodium and water, which then leads to vasodilation and decreases arterial blood pressure. Lisinopril is a frequently prescribed ACE inhibitor. Patients will need to be monitored for a dry, non-productive cough known as an ACE cough. If the patient develops an ACE cough, the medication is usually stopped. Beta blockers are prescribed to block the effects of epinephrine released upon activation of the compensatory mechanisms. Metoprolol is a frequently prescribed beta blocker. Fatigue is one of the most reported side effects of beta blockers. You'll note in the slide below there is a list of beta blockers, and if you'll note, all of them end in OLOL. This is a good way to be able to identify your beta blockers for testing purposes. Cardiac glycosides, or digoxin, improves the heart's ability to pump blood by making contractions stronger. It also decreases heart rate, which then in turn decreases the workload of the heart, allowing it to fill and pump blood more effectively. Patients who are on digoxin will need to be monitored for digoxin toxicity. Nurses need to always check the patient's apical pulse for a full minute prior to administration of digoxin. Another clinical consideration is digoxin toxicity. Patients will need to be monitored for this frequently, and typically occurs in patients that are dehydrated or have impaired kidney function. Please also be aware that digoxin can cause an inverted T wave on an EKG shown below. Okay, I have a couple of review questions before we get to the conclusion. Question number 1. Epinephrine and norepinephrine are released by the sympathetic nervous system. True or false? The answer to question 1 is true. Epinephrine and norepinephrine are released by the sympathetic nervous system when there is a decrease in cardiac output. Question number 2. BMP is a laboratory test used to diagnose heart failure. True or false? The answer to question 2 is false. BNP is a laboratory test used to diagnose heart failure. BMP is a basic metabolic profile which, while a diagnostic test, is not used for diagnosis of heart failure. In conclusion, heart failure results in decreased cardiac output. The decrease in cardiac output signals the sympathetic nervous system to release epinephrine and norepinephrine into circulation to preserve blood flow to the circulatory and nervous systems. The decreased cardiac output also signals the kidneys to activate the renin-angiotensin-aldosterone mechanism to reabsorb sodium and retain water to increase vasoconstriction and blood pressure. Treatment of heart failure is aimed at reversing the effects of the compensation mechanisms as well as in improving cardiac output. This can be accomplished by non-pharmacological and pharmacological means.